advertise it, they'll be walking in.
Yeah, don't worry.
Good afternoon. Welcome back to Grand Rounds. Please remember to fill out the attendance records, and also please remember to fill out the program evaluations. And if you could give us ideas in regards to future speakers or future topics you'd be interested in, the CME committee is always happy to review those. Today, it's my pleasure to introduce Dr. Stephanie Faubion. Dr. Faubion is a pediatrician and an internist. She's currently a consultant in the Division of General Internal Medicine at the Mayo Clinic. She's also a consultant in the Division of Preventive Occupational and Aerospace Medicine at the Mayo Clinic. She's assistant professor of medicine at the Mayo Clinic College of Medicine, and she is also director of the Women's Health Clinic in the Division of General Internal Medicine at the Mayo Clinic. And she kindly accepted our invitation today to drive down from Rochester and update us on management of postmenopausal symptoms in 2014. Please join me in welcoming Dr. Faubion.
Well, thank you very much. I'm delighted to be here, and thanks so much for the invitation, and I'm excited to talk to you guys. So I have my women's health hat on today. So just a poll of the audience. Who's in the audience? So raise your hand if you're family medicine or internal medicine. Yep. How about gynecology? A few. And surgical specialties? Great. Wonderful. So a smattering of a lot of different specialties. So I'll try to keep this fairly broad. I wanted to talk to you today about individualizing management of menopausal symptoms. There are going to be some 50 million postmenopausal women in this country by 2020. So not just gynecologists are going to be managing these women, and so it's important for all of us to understand what to do with hormone therapy when your patients come in and ask about it. Sadly, no financial disclosures. Learning objectives. So this is an ambitious list to get through in the next 50 minutes, but one, I hope that you will feel more comfortable prescribing hormone therapy to appropriate candidates, that you will be able to list risks and benefits of estrogen and progesterone therapy versus estrogen therapy alone, that you will be able to describe the differences between different formulations and routes of delivery of estrogen and progesterone, that you can inform your patients about the differences between FDA-approved and compounded bioidentical hormone therapy, and finally, that you can interpret current evidence regarding cognition, mood, and hormone therapy in menopause. So we're going to start with a case. So case one, and you have your audience response system. 53-year-old woman, she's a gravida 3, para 3. She status post-hysterectomy in her 40s for some abnormal uterine bleeding. Her ovaries remain. The pathology was benign. She's on estrogen for vasomotor symptoms since the age of 48. Her vasomotor symptoms return with any attempt to stop her estrogen therapy. She has a past history of hyperlipidemia. She's on a statin for that. She has no known history of heart disease, diabetes, or hypertension. She's never smoked. Her father had heart disease at 50, and mother has hyperlipidemia. So, based on what you know about risks associated with hormone therapy, how do you advise her? 1, stop hormone therapy as a risk of heart disease is increased. 2, continue hormone therapy as the risk of heart disease is not increased. 3, stop the hormone therapy as a risk of stroke is increased. 4, stop the hormone therapy as a risk of breast cancer is increased. Or 5, stop the hormone therapy as a risk of heart disease, stroke, and breast cancer are all increased after 5 years of hormone therapy. So please select your answer. I can sing the Alex Trebek song, theme song, but you probably don't want me to. Okay. Do we have an answer? Tim, do I need to click anything? There we go. Okay, so 48% of you said stop hormone therapy as a risk of heart disease, stroke, and breast cancer are all increased after 5 years. 10% of you said stop because their stroke risk is up. 35% said continue. So the correct answer which I will hope to argue here, is continued hormone therapy as the risk of heart disease is not increased and may actually be decreased on hormone therapy. So July 9, 2002, this was the atomic bomb for the hormone therapy world. Women's Health Initiative study came out. Does everybody remember that day? Phone calls all over the place. Should I stop my hormone therapy? What do I do? So following the Women's Health Initiative study, there was a huge drop in the use of hormone therapy. So pre-WHI, about 40% of postmenopausal women used hormone therapy, and 90% of those women who had had a hysterectomy used hormone therapy during their 50s for about 4 or 5 years. But after WHI, within 18 months, almost half the women dropped their hormone therapy. And the use of all types of hormone therapy systemically continued to decline now, such that I think we're down to around 8% use now. Less than a third of hysterectomized women currently use estrogen. So Phil Sorrell published a paper last year that was fascinating. He said there's a mortality excess related to estrogen avoidance. So for all of those hysterectomized women in their 50s who are not taking estrogen over the last 10 years, how many lives do you think we might have lost? The estimate is 50,000. It's pretty impressive. His range was somewhere between 19 and 90,000, but the middle was about 50,000. So why the skepticism about hormone therapy now? Well, the message regarding the risks is not clear. So when they published that data, the message was, you need to stop your hormone therapy. It is dangerous. But they didn't talk about, well, does the risk differ by decade, by 50s, 60s, 70s? Does it matter? Did it matter if it was estrogen plus progesterone versus estrogen alone? They just said, stop it, it's bad. Mistrust of pharmaceutical companies, so people are trying to sell you something. Pressure from peers, you're taking that stuff? You're taking that hormone therapy? Non-hormonal options are now available for osteoporosis and sleep. There's Boniva, there's Fosamax for that, so you don't really need to, in fact, estrogen therapy is second line for osteoporosis treatment now. Sleep, there's Ambien, Lunesta, Sonata, there's other things to help you sleep at night. Bioidentical hormone therapy, that's a whole other topic, but this has filled the void. This sucked into the vacuum where hormone therapy left. The bioidentical hormone genre has come in to where they're going, okay, here's a safe option for you. You can take this. So that really accounts for a lot of the decrease in prescriptions now as well. And the pendulum swings in medical recommendations. So we've gone back, forth. Hormone therapy is the best thing since sliced bread. Now it's terrible, you shouldn't take it. And frankly, patients are weary of this and a little bit leery of what you're telling them. And physicians are confused too. I talk to a lot of providers, internists who are like, this changes every other day. I don't know what to tell my patients. So I promise I'm not going to rehash the Women's Health Initiative study top to bottom, but just to review with you. It was a big study, 27,000 women, randomized placebo-controlled trial, and it was designed not to assess effectiveness. So they weren't trying to say, was it effective for hot flashes and night sweats? They really wanted to say, what are the long-term health benefits or risks of hormone therapy? Average age 63, good 10 years after menopause, 50 to 79. So think about that. They put 79-year-old women on hormone therapy. The primary beneficial outcome was heart disease. Primary adverse outcome was invasive breast cancer. And they used a combination of either conjugated equine estrogens or conjugated equine estrogens plus medroxyprogesterone acetate, otherwise known as Prempro. So the combination arm was stopped at 5.6 years due to an excess in breast cancer risk, but they also noted 7 more heart disease events per 10,000 women per year and 8 more strokes. The estrogen-only arm was stopped after 7.2 years due to an increased risk of stroke that was not offset by heart disease protection in the hormone therapy group. So the 13-year follow-up was just published last fall in JAMA. And what I want you to pay attention to here is the heart disease risk. So estrogen only, 11 fewer cases per 10,000 women per year for women in their 50s. For women in their 60s, it's still not increased. Stroke risk, not increased for women in their 50s on estrogen only. And here there are the statistics on the invasive breast cancer and all-cause mortality. And again, so the estrogen-only group for breast cancer, after the analysis that came out last fall, statistically significantly decreased risk of breast cancer in the estrogen-only group. All-cause mortality was significantly decreased in all women in their 50s, estrogen plus progesterone and estrogen alone. But again, not increased in women in their 60s as well. So what are the recent and ongoing trials about hormone therapy? So this is a quick summary, but the DOP study, Danish Osteoporosis Prevention Study, was published in late 2012. This was the first study to actually look at the group that it's most salient for. So newly menopausal women, they had to be within 3 and 24 months of their last period to get in the study. 1,000 women, they were randomized to 10 years of therapy. This trial was supposed to be 20 years of active treatment. But what happened was the Women's Health Initiative study came out, they bailed off hormone therapy, and we got 10 years of active treatment data. They found a significant reduction in the primary endpoint, which was a composite of mortality, heart failure, and MI, and the reduction was by half. Then they followed for an additional 6 years after that. So after 16 years of total follow-up, it remained significantly decreased. 0.61 was the hazard ratio. The ELITE trial, I'm not going to go into too much, but it's also studying the timing since menopause, less than 6 years versus over 10 years. And those results are expected out later this year. Their endpoint is going to be carotid intima media thickness and carotid artery calcification. So instead of looking at mortality or MI, they're actually looking at the disease process. And then the KEEP study, we have one of the primary investigators at Mayo, Virginia Miller. For your study, you had to be within 36 months of your last period to get in. They used either Premarin plus micronized progesterone, so conjugated equine estrogens given cyclically, or an estradiol patch plus micronized progesterone versus placebo. So 700 women, the endpoints again were the actual disease process, carotid artery intima media thickness and coronary artery calcification, and they looked at 4 years. No difference between the groups. So the theory is that these women may just be too young and too healthy to have developed any disease yet, but they are going to continue to follow these women out over time to see if this 4-year period of hormone therapy has any effect. This study is not published yet, but is in press and will come out in the Annals of Internal Medicine this year. So the take-home point here is the body of scientific evidence suggests that estrogens given early in menopause for management of menopausal symptoms are not harmful to the cardiovascular system, and if anything, may slow progression of atherosclerosis and reduce the future burden of cardiovascular disease. Okay, so we're going to move to the next case. So a 52-year-old Gravida 1 Para 1 had her last period 3 years ago, and she's coming to you for advice on hormone therapy. She was seen by another provider who started her on oral conjugated equine estrogens and medroxyprogesterone acetate, so Provera, for management of moderately severe vasomotor symptoms. She has no contraindications to hormone therapy and would like to continue, and her friend said, you know, I'm on the patch, or I have the gel, and she wants to know what her options are, and what would you recommend? So, question. Available data comparing oral and transdermal estrogen therapy suggest all of the following are true except which one? 1, blood pressure may be increased with oral, but not with transdermal estrogen. Venous thromboembolism risk is increased with oral, but not with transdermal estrogen. 3, stroke risk is increased equally with both. 4, lipids, coagulation factors, C-reactive protein, are adversely affected by oral but not transdermal estrogen therapy. Or 5, sex hormone binding globulin is significantly increased and free testosterone decreased with oral but not with transdermal estrogen therapy. Okay, so 36% of you said stroke risk is increased equally in both, and that would be an incorrect answer, and that is correct. So most of you got it right, but there's still a big range there. So the incorrect answer was oral and transdermal estrogen therapy increases stroke risk equally. Good. Okay, so I put this slide up here to give you a list of what are the products out there that combine oral estrogen and progesterone in the United States. This one is the combined products as well. The last one, sorry, was the individual ones separately. Here are the combined products. Here are the transdermal products that are out there. Most of these, whoops, go back. Most of these over here are patches, but we also have gels. Estrozorb, Estrogel, Divigel, Elestrin is also an emulsion. Sprays, Evamist, but then you get into these combo things. But notice these are bioidentical with the exception of the progesterone component down here, norethindrone and norgestimate. So by and large, the transdermal estrogen products that are available, they all have bioidentical estrogen in them. Dose equivalencies. So if you're switching somebody back and forth, or if they come in an oral and you want to switch them to transdermal, what's the equivalency? So 0.625 milligrams of conjugated equine estrogens or Premarin is roughly equivalent to 1 milligram of estrase orally. I say roughly because the Tmax of estrase is 2 hours, so it's a very short-acting drug. And it's almost truly a BID dosing drug. So if you give a woman estrase in the morning, she's probably going to have hot flashes by the evening. The equivalent in patch is estradiol 0.05 milligram patch. And again, if you notice these transdermal products that are listed below here, very low doses. So 2 packets of Estrozorb is 0.05, 2 pumps of Elestrin is 0.0375. So for the most part, these are low dose. So what's the difference between oral and transdermal estrogen? Well, oral, of course, has first-pass metabolism through the liver, so what does that do? It elevates SHBG, which lowers free testosterone. It also elevates triglycerides, lowers LDL particle size, increases thrombotic factors, and increases C-reactive protein. Other adverse effects, it can affect blood pressure in both hypertensive and non-hypertensive women. So it's almost an idiosyncratic reaction, but oral estrogen can increase blood pressure. What's the heart disease risk? Is there a difference between oral and transdermal estrogen? Yes, there is. There's a lower risk for MI with transdermal estradiol than with oral, and the relative risk is 0.77, so it's not insignificant. There are also more favorable effects or less deleterious effects on cardiovascular disease markers like blood pressure, triglycerides, LDL particle size, coagulation parameters, C-reactive protein, and activated protein C. What about stroke risk? Is there a difference between transdermal and oral estrogen? Yes. There is an increased risk with oral estrogen, but not with transdermal. And we think about this as, think of the birth control pill. It increases risk of clot. These women don't have, they're not developing vascular disease, and that's the cause of the stroke, but it's more a thrombotic effect. So the increased risk is due to thrombosis. Compared to hormone therapy non-users, if you're on transdermal, there's no increased risk, 0.95, but if you're on oral, 1.28, it is increased. Direct comparison of transdermal to oral, 0.74 for transdermal, so significantly decreased risk of stroke. What about venous thromboembolism risk? Is there a difference between oral and transdermal? Yes. Oral, you have first-pass metabolism that alters the balance between procoagulant factors and antithrombotic mechanisms. Esther's study was the one that really looked into this. It was published in 2007. So the risk with transdermal was 1, not increased. With oral estrogen, 4-fold increased risk of compared to transdermal. The greatest risk of clot is in the first 12 months of therapy. So they did an extension study where they actually looked, okay, what if you have one of the mutations that increases your risk of clot? What does it do then? So factor V Leiden mutation increases your risk of clot by 3.4-fold. Prothrombin G mutation, 4.8-fold. Oral estrogen, 3.5. But if you combine them, oral estrogen plus a mutation is 25 times the risk. But transdermal, no increased risk beyond that of the mutation. So if you have a woman who has a history of a clot, it's not that she can't use estrogen, it needs to be transdermal. And it's not that she's not at increased risk of clot, she is, but it's due to the mutation, not the estrogen. Screening for a prothrombotic mutation is not recommended in the absence of a strong family or personal history of clot. So let's talk about obesity and clot risk and the difference in the estrogens. So your risk of a venous thromboembolism if your normal weight is 1, not increased, overweight 2.7 times, and if you're obese 4 times. With oral estrogen, multiply it by 5. But there's no additional increased risk if you're on transdermal. So again, for overweight or obese patients, transdermal is a much safer option. The E3N study looked at breast cancer risk between oral and transdermal estrogen. Is there a difference? Well, E3N said no. There's no difference in breast cancer risk between oral and transdermal estrogen. There is some interesting data, and Jennifer Harvey in 2005 published this. She's a radiologist, but she was looking at breast density and estrogen, whether you're on oral or transdermal, and she found that there's a lower mean breast density score if you're on transdermal versus oral. There's less of an increase in breast density on transdermal. You're more likely to have no change in the breast density, but we don't know if this really translates into decreased breast cancer risk, so that's unknown. Let's switch over to progestogens. Let's compare Provera, medroxyprogesterone acetate, versus Prometrium, micronized progesterone. So micronized progesterone has a favorable action on blood vessels and brain. We know that it lowers blood pressure, and it doesn't counteract the favorable effects of Premarin on HDL cholesterol, and that was the PEPI trial. When you look at medroxyprogesterone acetate, however, it has glucocorticoid properties, so women can have water retention, which they generally don't like, and it can have slight adverse effects on glucose metabolism and insulin. What about venous thromboembolism risk and the progestogens? So back to the ester study. We know that micronized progesterone, again Prometrium, and the pregnane derivatives don't have an increased risk, but the norpregnane derivatives do have an increased risk. 3.9 was the odds ratio. Pooled analysis of ester and E3N just point to micronized progesterone being the safest option. So what about breast cancer risk and progestogens? The E3N study showed that hysterectomized women who used estrogen, the relative risk was 1 if you had that combined with the Prometrium, the micronized progesterone. 1.6 if you were on dydrogesterone, but 1.69 if you use another progestogen. And between those others, there was no significant difference. So the conclusion, progestogen choice matters, and micronized progesterone or dydrogesterone may be safer options. So they also have, there's also been a Finnish study looking at, is it better to look at sequential use or continuous hormone therapy when you look at the progestogen regimen? So is it better to go for the first 12 or 14 days of the month, or is it better to go the lower dose continuously? And this study showed that there's a higher breast cancer risk with continuous use of a progestogen compared to sequential. And that didn't matter how long you were taking it, less than 3 years, 3 to 5 years, or greater than 5, the risk was still higher for continuous across all durations of therapy. So the clinical pearl here is that current data favor the use of transdermal estradiol and micronized progesterone over CEE-MPA with regard to heart disease risk, stroke, venous thromboembolism, and breast cancer risk. Okay, shifting gears, case 3. A 48-year-old woman, gravida 3, para 3, last period 9 months ago. She has moderate hot flashes and night sweats. She's got some vaginal dryness. She's heard about bioidentical hormone therapy. She's consulted another practitioner who performed salivary hormone levels and said, you need individualized custom compounded bioidentical hormone therapy just for you. And she says, what do you think about this? So what are you going to tell her? Which one of the following statements would you include in your advice to her? 1, custom compounded bioidentical hormone therapy has fewer risks than commercially available hormone therapy. 2, salivary hormone level testing will provide useful guidance. 3, there are multiple options for FDA-approved bioidentical hormone therapy. 4, custom compounded bioidentical hormone therapy products are submitted to the same safety standards as commercially available hormone therapy products. Or 5, there is no role for the use of compounded bioidentical hormone therapy. Okay, so a mix here, but 48% of you said no role for the use of compounded bioidentical hormone therapy, and 35% said there are multiple options for FDA-approved bioidentical hormone therapy. So the 35% are correct. There are multiple options for FDA-approved bioidentical hormone therapy. So let's talk about this a little bit more. So what's the difference between bioidentical hormone therapy and compounded hormone therapy? So bioidentical just means it's chemically, structurally the same as what your body used to make. Compounded just means that your prescription is taken to the pharmacist, the compounding pharmacist, and they mix whatever it is you told them to mix. It can be hormones, it can be anything else, it can be bioidentical hormones, it can be non-bioidentical hormones. Now, there are multiple options for FDA-approved bioidentical hormone therapy that can be delivered orally, transdermally, and vaginally. And there's a really nice chart of these options on the NAMS website, the North American Menopause Society. They also have a really good patient information section too, so I always use they have explanations about bioidentical hormone therapy for your patients too. So what's the deal with the bioidentical compounded stuff? It's not regulated by the FDA. There are concerns regarding batch-to-batch variability. So the pharmacist mixes it 1 month, it's one thing. The next month, it might have a different concentration of estrogen in there. Purity is a problem. So the whole Massachusetts compounding pharmacy fiasco in 2012, that they had contaminated steroid injections that killed several people. So that's also a concern. And then safety and efficacy. So when these women get these prescriptions from the pharmacist, it doesn't come with a package insert. So their assumption is, must not have any concerns, okay? There's no black box warning because they don't even get a package insert. And then they think it's effective, and or they think it's more effective than what they can get in the pharmacy that's FDA approved, and that's just not true. But are they ever useful? Yes, I can give you a couple of circumstances in which you might want to consider compounding a hormone for someone. One would be micronized progesterone is, the vehicle is peanut oil. So if you have a patient that is peanut allergic, you can have your pharmacist put it in olive oil. Another option or another circumstance would be vaginal estrogen products. So I've had multiple women who react to a preservative in the cream, the Premarin cream or the esterase cream. They can't tolerate the other vaginal options, and you can easily have your pharmacist make it up in a preservative-free base. So there are circumstances in which you might consider compounding. Then we all got to face Suzanne Summers, right? Anybody come in with the book and say, "Doc, I want what she has"? Well, who wouldn't want what she has, right? All over the internet, they're bombarded with information about bioidentical hormone therapy and how this is the way they should do it, and it's natural, and so what do you do? So More Magazine, I don't often quote More Magazine, but they did a nice study last fall, and I actually have the PDF on my computer, and I hand it out to patients when they come in asking about this. They did a study. They sent the same prescription to 12 compounding pharmacies in the United States, and 10 of them were online, and 2 of them were brick and mortar. And they got the prescriptions back, and they had them analyzed in the lab. And here's what they found. The estradiol in this prescription ranged between 96 and 260% of what was on the label. Way high on the estrogen component. The progesterone was only 60 to 80%, way low. So you're going to see what's going to happen. They're going to bleed because they have way too much estrogen and not enough progesterone. None of these would have met FDA standards. To make FDA approval, it has to be between 90 and 110% of what's on the label. So none would have passed FDA approval. And this also has a number of quotes from leaders in the menopause world, so it's a really nice article. So what's in bioidentical hormone therapy? So that when they bring you their prescription, their little cream in a jar, how do you sort out what they're actually taking? So estradiol is E2. It's predominant in premenopause. It is FDA approved. It's 12 times as potent as E1, which is estrone, and 80 times as potent as estriol or E3. Estrone, E1, dominant postmenopausal women, FDA approved. E3 is estriol. It's produced in the placenta during pregnancy. It is not FDA approved. E3, you're going to hear some about. There have been studies in it. It's the weakest estrogen. It has been shown to be effective for hot flashes and vulvovaginal atrophy. Does nothing for bone, and there's no evidence with regard to safety in the breast or the endometrium. So when they come in with that prescription that says they're unbiased, what the heck is that? So it's 20% E2 and 80% E3 on a milligram per milligram basis. So if they come in on bias 2.5, that means they're on 2 milligrams of E3, half a milligram of E2, and you can pretty much discount the E3 component because it's 1/80th of the potency. So it's pretty much that they're on 0.5 milligrams of estradiol, but the extra 0.25 is in there from the E3. Triest is 80% E3, 10% E2, and 10% E1. So again, the majority of what they're going to be on is still E2. Caution regarding pellets. So I've had several women come into me that have had hormone pellets placed elsewhere. They are often not made well and they degrade very quickly, and these women can have extraordinarily high hormone levels that you really can't do anything about. You just have to wait it out. But that's a tough one to deal with. So what about progesterone cream? This is available over the counter. It's called Progest. It's available without a prescription. The problem is that the percutaneous absorption is erratic and it's not reliable, and you can't rely on it to protect the endometrial lining. It does not protect bone. It may be somewhat helpful with hot flashes. What about DHEA? So there are proposed uses all over the place, from curing cancer to fatigue and depression and fibromyalgia, et cetera, little evidence to support that. There is a study that was recently completed at Mayo using vaginal DHEA for vaginal dryness and breast cancer survivors that did show some effect for that population. So there may be some uses for DHEA, particularly intravaginally. So what do you do when they're telling you they've had salivary or blood hormone level testing or they want it? Well, the problem with levels, hormone levels, they vary by the hour, literally, or from day to day, the time of the cycle, et cetera. So you can check them one day, they're completely different the next day. We don't have any well-established reference ranges, especially for testosterone, so we really don't know where it should be for any one woman. There's no evidence that monitoring improves safety, and levels don't necessarily correlate with symptoms. So I tell women, we don't know at what level hot flashes are going to be controlled, or vaginal dryness is going to be treated, or sexual symptoms are going to be treated, so we don't even know what we're aiming for. So some of these bioidentical compounding folks say, you should be at X level. Well, that's sort of the antithesis of individualizing hormone therapy, isn't it? To say that everyone needs to be at the same level. And current practice is to let symptoms rather than levels guide therapy. So the clinical pearl here is, for most women who are acceptable candidates for hormone therapy, a commercially available, FDA-approved bioidentical option is appropriate, with therapy tailored to symptom relief rather than to a specific hormone level. Okay, so last case, a 54-year-old gravida 2 para 2 presents to you with some mild vasomotor symptoms, but says, I'm irritable, I'm anxious, I don't feel like myself, and I'm worried about my family. I mean, I'm just awful. Last period 15 months ago. She's also concerned about her family history of Alzheimer's disease. Her mother had Alzheimer's at 70. And she has really no history of depression or a mood disorder. So which of the following is true regarding menopause, mood, cognition, and hormone therapy? 1, hormone therapy increases the risk of Alzheimer's disease, whether started early or later after menopause. 2, conjugated equine estrogen and medroxyprogesterone acetate may be more beneficial to the brain than estradiol and micronized progesterone. 3, the majority of women will experience depressive symptoms during menopause. Or 4, estrogen has shown efficacy in the management of depression in menopause. Great. So 52% of you said estrogen has shown efficacy in the management of menopause, or of depression and menopause, and that is correct. Alzheimer's disease in women. It's the 6th leading cause of death in the United States. Of the top 10 leading causes of death, Alzheimer's disease has the greatest sex difference. 20% more women than men died of Alzheimer's disease between 1999 and 2008. There's an increased incidence of Alzheimer's disease in women compared to men, so it's not just that we're living longer than men. The prevalence will triple by 2050 at a cost of $20 trillion. So we've been talking about the timing hypothesis, how it makes a difference if you start estrogen early versus late with regard to heart disease, right? So now we're going to talk about it with regard to the brain. I'm going to give summary points. There's a lot of research behind it, but here are the boiled down nuggets. Estrogen-containing hormone therapy is neuroprotective in younger women. There's a primary prevention of neuron loss. There's reduced incidence of Alzheimer's disease with early intervention, and the Women's Health Initiative memory study, WIMS, showed increased memory problems in the older cohort, but these 3 studies, Mirage, Kaiser, and Cache County, showed decreased memory problems in younger women. So, because it's impossible to do a study of hormone therapy in dementia, think about it, you would have to start them on estrogen therapy at 50, and continue it for 20 years, because they don't get dementia in their 50s and 60s. It's really kind of 70s and older. Continue it for 20 years, and then see who gets dementia and who doesn't. Well, they're never going to repeat the Women's Health Initiative study again. It was the estimates are between $500 million and $1 billion to do that study. And by the time we got finished with it all, we were saying, yeah, but we don't use that kind of hormone therapy anymore. So the same thing would happen again, so it's not going to happen. So neuropsychological tests of verbal memory it can be a marker. So they have normative standards, they have validity for predicting dementia, and they can be a proxy for dementia risk. So randomized trials of hormone therapy and verbal memory show that there's evidence of benefit of estrogen alone on cognitive function in younger postmenopausal women. Neuroimaging studies provide support of this biological plausibility of early benefit of estrogen. So in other words, your brain looks better on estrogen. You remember the 1970s commercial where here's your brain on drugs? Does anybody remember those, or is this just me? Okay, so your brain on estrogen looks better than your brain off estrogen. However, conjugated equine estrogens and medroxyprogesterone acetate does not confer cognitive benefits and may lead to memory decline regardless of timing. So, as my friend Pauline Mackey, who studies this all the time, says, this stuff is toxic to the brain. CEA and MPA is toxic to the brain. So if you give memory studies to women after 6 weeks on Prempro, they will have a decline in verbal memory. Okay, let's shift gears, mood and menopause. So there's a window of vulnerability. So during the menopausal transition, women have a 2 to 4-fold increased risk of depressive symptoms and major depression, perimenopause. Fluctuating hormone levels versus absolute levels. So it may not be that a low level is problematic, but more the up, the down, all over the place that's the problem. And vasomotor symptoms are correlated with mood problems. So the more trouble you have with hot flashes and night sweats, the more trouble you're probably going to have with mood. The greatest risk, however, is if you've been depressed before. So if you have a history of depression, you're really vulnerable at that time frame where we go through menopause. And those subgroups that tend to have problems with the hormonal milieu changing, like those who have postpartum depression or those with PMS symptoms and where their mood really tanks right before their period, those are the folks who are most vulnerable during this time frame. Anxiety in menopause is a little harder. So anxiety is prevalent. 23% of women before midlife have trouble with anxiety. The SWAN study showed that women with a baseline risk, so a history of anxiety or long-term stressors, no increased risk of symptoms at menopause. However, women not at increased risk had a significant problem with menopause. So it's also difficult to separate hot flashes from an anxiety disorder when you're doing a questionnaire. So women report palpitations, they report sweating and flushing and being embarrassed, and it's awkward to be in a social situation, and you tend to avoid those situations, and then you get more anxious if a hot flash comes. And so it's tough in studies to separate these two, and we don't have really good validated questionnaires to do this yet. So mechanistically, how might estrogens affect mood? So we know that estrogen results in increased 5-HT synthesis and availability, and it promotes norepinephrine availability. So it increases serotonin and norepinephrine. The effect of hormone therapy on mood. Estradiol in perimenopause is as effective as monotherapy with an antidepressant for major depressive disorder. It's pretty impressive. So if you have a woman coming in with vasomotor symptoms who's also having mood problems, hormone therapy may take care of that. If, however, they're suicidal, don't rely on hormone therapy to take care of that alone. So this is supported by 4 small studies, including 2 randomized controlled trials. Transdermal estradiol had a little bit better effect than oral. And it may be used as an augmentation strategy in those with an unsatisfactory response to antidepressants. So we're actually developing a much closer relationship with our psychiatry department. They have women who come in at midlife. They're treating them with antidepressants. They don't get better. They send them to us, and we try hormones, and often it's pretty successful. No studies have thoroughly examined the effects of hormone therapy on anxiety in peri- and postmenopausal women. What about other hormones in mood? So progestogens, we know that MPA may lessen beneficial effects of estrogen. I'm just loving MPA. I mean, can you tell there's a theme here? We don't know about the effect of micronized progesterone yet. Testosterone is associated with improved mood and anxiety in postmenopausal women with low levels. And raloxifene, mixed results. One study showed no change at 52 weeks, and one showed improved mood at 4 and 8 weeks in women with treatment-resistant depression. So how are you going to treat women at midlife with mood disorders? So women with a history of depression and known previous adequate response to a particular antidepressant, use that same antidepressant. First-time episode, use an SSRI or SNRI, and there's some examples. And this would be first line for those with pretty severe symptoms, those with a history of depression, or those who are suicidal. In symptomatic perimenopausal women with moderately severe hot flashes, hormone therapy plus minus an antidepressant would be reasonable. And don't forget the non-pharmacologic strategies like lifestyle modification, exercise, a healthy diet, stress management, cognitive behavioral therapy. So the clinical pearls here, although hormone therapy is currently not indicated for the treatment of cognitive complaints or the prevention of dementia, evidence suggests that it reduces the risk of Alzheimer's disease, particularly when started in younger women. CEE and MPA increases the risk of Alzheimer's disease regardless of the timing. Little is known about the cognitive effects of other combination hormone therapy regimens, so including micronized progesterone. And the menopausal transition is a window of vulnerability for the development of new or recurrent depressive symptoms or depression. Thank you very much. So, yeah, questions already.
Hi, I'm Tim Leeds. I'm OB-GYN. How does a pediatrician become an aerospace consultant?
I was going to explain some of that. Okay. I have not practiced pediatrics since 1990, so I have done internal medicine. And when I came to Mayo, I came in through general internal medicine and transitioned to PrevMed, which also does OC and aerospace. I'm not in the OC and the aerospace area. So I did the executive health program, and now I'm in both PrevMed and general internal medicine. So I do a little bit of executive health and mostly women's health. Good question there. Yeah, I'm sure it was. Aerospace. He said aerospace, and I was like, oh boy, here we go. Yes. Okay, so the question was testosterone for postmenopausal women, and for whom and how do you monitor? Is that the question? Okay, so boiled down, a whole lecture in an hour, boiled down to a couple of nuggets. Postmenopausal women, the most appropriate candidates for testosterone. One, a woman who has lost her ovaries before the natural age of menopause. Those women have lost about half of their testosterone production. So if they've had a oophorectomy at 35 and you give them estrogen therapy and they're still having hot flashes and night sweats, it may be testosterone deficiency, and that would be a woman that I would definitely consider trying testosterone. We give it topically. Response should be within 8 to 12 weeks. If they haven't responded by 16 weeks, they're not going to, and you should take them off. So monitoring, we check levels, not to make sure that they're getting to a certain level, but to make sure they're not getting into the male range. We check it about 3 months and then continue to monitor periodically from there. So you really don't want to create any irreversible changes. While you can get hair loss and acne, and those can be irreversible, the voice changes, the clitoromegaly, those are not reversible. So you need to monitor them carefully. The grayer group than that would be the postmenopausal woman that says, my libido's terrible. So opinion, and this is my opinion, most of those women have some other cause for a low libido. And this is working in a sexual medicine clinic all day, every day, pretty much. So most of the time, it's not just a testosterone problem. If we get down to, I really can't find anything else, give them a trial of testosterone. It's pretty safe. It's not going to have any major side effects, especially within about 3 months. If they come back in 3 months and they go, yeah, it didn't do anything for my libido, which is what I would expect, probably stop it then. Definitely stop it then. No. Yes, exactly. So the question was, what formulation do we use? So the male preparations are 10 times what women need. So you've got to find a way to cut that, and cutting a male preparation down to size for a woman is just too difficult to do. So we use 1% testosterone in Vanicream, and we use it in a meter dose dispenser where 2 clicks equals half a gram, and we start with half a gram applied topically.
The new product that's out, the Duo-V, that's estrogen with a serum. Is there any data indicating anything on that?
Yeah, so Duo-V is it's conjugated equine estrogens plus bazodoxifene, and it's 0.45 of conjugated equine estrogens. You know, I've thought, why did they do this drug? Why? What's the point? So Wyeth owns Premarin, CEE. Pfizer owns bazodoxifene. Pfizer bought Wyeth. So I think that's they needed a purpose for the drug. So they have these two. Now, what I wish they would do with that, why would you use this? Well, in someone who doesn't tolerate progestogen well, somebody who tanks with their mood every single time you try to put them on a progestogen, bazodoxifene might be a really good option because you're avoiding that. I wish they would market them separately because I have a lot of patients that I would like to use something other than a progestogen in them, and bazodoxifene would be a very nice way to protect the uterine lining. But they're marketed together, so then you run into the difficulties with the oral estrogen. So I think it's great in that there's another option available for women. I really haven't found the particular circumstance in which I would use it yet. Yes? We'll go here first. Oh, yeah.
With these cardiovascular studies, did they include patients that had high cholesterol and hypertension that were treated? And if so, I was trying to find the actual quote on whether, if you're going to use a combination, there's lots of information on estrogen only. I'm very comfortable with that. But what about the combination, the E2 plus a progesterone for patients with known cardiovascular risk factors?
So risk factors, not disease, right? Okay, so back to the Women's Health Initiative study. That study was all comers. So these women were smokers, they had existing heart disease, they had diabetes. So the Women's Health Initiative study was done in that population. The current studies, like the KEEPS trial, you could not have disease going in, so you had to have below a certain level on your coronary calcification study to get in. In other words, they wanted women who were clean slates and then follow them from there on. Now, what do we do in practice? Cardiovascular risk factors are not a contraindication of hormone therapy, and we wouldn't use them as such. So we would have no issue with giving someone an estrogen and a progesterone, micronized progesterone. On the other hand, if someone has had a stroke, wouldn't go there. Or if someone has had an MI, I wouldn't go there. Now, the iffy area is probably women with the microvascular disease, where They have reactivity to their vessels. Those women actually do often stabilize if you give them estrogen. But they don't have documented atherosclerotic disease. Okay, they just might, on the stress test, they can challenge them and they have spasm. But, you know, there's not a lot of data behind this, and you really need to work with your cardiologist to figure out would you give estrogen to somebody like that. But somebody with diabetes, hypertension, hyperlipidemia, I wouldn't have any problem with that. If anything, it's going to protect their heart. How long? Okay, well, that's a quagmire. So the question is, how long do you use hormone therapy? When do you stop it? The mantra has been use the lowest dose for the shortest amount of time needed to control symptoms. There have been studies like DOPS that women are on it 10 years and they do really well and their disease risks are lower. ACOG came out with a practice bulletin number 141 published in January that said women don't need to stop it at 65, which I found very useful, and I actually use it with the insurance companies to get hormone therapy paid for, which is often cut off at 65 for a lot of my patients. What do we do in practice? Women use it for as long as they need it. We discuss risks every year. We come back and they say, how are you doing? Are you having symptoms? Do you think you're still benefiting from it? And we say, okay, here are the risks associated with it. And if they want to continue through their 50s, I would have no problem with that. If they get to their 60s and we start having more conversations about, okay, the balance may be tipping a little bit, but it still comes down to a quality of life issue. And I will tell you, I have plenty of 75-year-olds in my clinic who still say, yeah, you can wrest it out of my dead hand later, but not now. So I think it takes individualizing. That's where the art of the thing comes in.
You mentioned briefly about the DHEA for the atrophic vagina. Could you please tell a little bit more how you use it and direction and dose and everything? And monitoring, if you monitor at all?
So the study that was done, and I don't think it's actually been published yet, but I've seen the abstract, was out at the breast conference a couple of months ago. They did 6.25 and 12, I believe. 6.25 milligrams and 12. And I think the 12 was a little bit more effective than the 6.25. We do use it in our clinic, and we compound it. In our pharmacy, it's been compounded into a suppository, but I've also seen it compounded in a gel. Use it daily for the first month, and then you can try to back it off to about 3 days a week. And experience, it does seem to help some women. I've had a couple of women come back and complain of a strange discharge, and they really didn't like it and wanted to stop. The other group that we're going to be looking at it in soon is Sjogren's patients. So Sjogren's disease, there may be a sex steroid problem as the mechanistic issue with Sjogren's, and so they've found in a few studies, I've just been looking into this recently, they have a DHEA processing problem. And so DHEA may help with the vaginal dryness associated with Sjogren's, where estrogen really doesn't help those premenopausal women at all. So that may be another option for DHEA, but you know, most of what we use is vaginal estrogen. No, monitor symptoms. Yep. Well, great. Thank you guys so much. If we can partner with you in helping your patients in any way, we're a consultative practice. We don't do primary care, but if we can help in any way, let us know. Thank you so much.